Can everybody see the slides?
Yes.
I think, okay.
Yeah, that's okay.
So we're going to talk about the use of BrosMed balloons in the treatment of hemodialysis AV fistulas dysfunction. This is my disclosures. Well, the epidemiology of the substitutive renal therapy, we were seeing an increase of incidence and prevalence of chronic renal disease all around the world. And this is because of aging of the population, the prevalence of hypertension and diabetes, among other factors. And you see the most utilized renal therapy substitutive is hemodialysis. And the vascular surgeon and the endovascular surgeon have a lot of challenge about this subject. As we can see in the guideline from the National Kidney Foundation, the vascular access remains a significant challenge for a patient with end-stage kidney disease. And we need to think about the next vascular access long before the current one fails. If it were only this easy, if every patient had a good AV fistula for good access, it would be a dream, but it's not what we see in the in our practice and everybody practice. We see that up to 20 to 60% of the AV fistulas fail maturation successfully for dialysis. And the venous stenosis is the most common complication after AV access. As we can see, this stenosis of the cephalic vein in the right arm. The AV fistula stenosis is maintaining effective functioning AV access is an ongoing challenge, as we talk about. Venous stenosis is often a result of intimal hyperplasia. And these stenosis are typically dense, fibrous, concentric, stiff lesions, and they're distinctly different from arterial atherosclerotic lesions. The guideline, the KDOC guideline, considers it reasonable to use balloon angioplasty with high pressure as needed as the primary treatment of the AV fistula and AV graft stenotic lesions that are both clinically or angiographically significant, or angiographically more than 50% of stenosis, and they are causing low flow or increase in the venous pressure, or increased bleeding time after withdrawal of the needles. Or, as you can see, the clinical significant lesions. We don't talk about surgery versus angioplasty anymore. In this case, the surgery is reserved for special situations to treat this stenosis, or when the endovascular treatment fails. But we know that balloon angioplasty for AV fistula stenosis had a poor primary patency, as we can see, even with drug-coated balloons. And we need multiple reinterventions. The primary patency is below 50 or 40% in 1 year. So these are the challenging lesions, and we need better devices to treat them. Today, we want to talk what would be the ideal balloon. It had to be low profile, low crossing profile, hydrophilic coating, good trackability, fast inflation and deflation time, high pressure resistance, and controlled angioplasty and dissection. I'm going to show some clinical case about our initial experience with the BrosMed balloons to treat these lesions, especially the Atropos and a semi-compliant over-the-wire O35 balloon, and the Hermes non-compliant over-the-wire O35 balloon. The differences of these balloons are a high range of diameters and lengths, and fast inflation and deflation times, and very good coating with hydrophilic inside and outside coating for good trackability. And as we can see, the Atropos have less deflation time compared with the concurrent. And the Hermes is the non-compliant for more stiff lesions that do not respond to compliant, to semi-compliant balloons. Even with large balloons have a low profile and they have the same hydrophilic coating from inside and outside. And also have fast deflation time compared to the concurrent. So with this low profile, most of the cases can be done with radial access or even distal radial access that can be minimally invasive and can lead to a rapid discharge for the patients and hemodialysis in the same day of the procedure. So I'm going to show you some cases that we use these balloons. The first one is a female patient with 62 years old, high blood pressure, diabetes mellitus, end-stage renal disease. Her hemodialysis access was a left brachial-axillary AV fistula. She had multiple interventions for venous stenosis, including cephalic arch stent graft placement, and had a new access dysfunction to the restenosis of the cephalic arch. We were planning to treat this stenosis, as we can see in this CT scan. But she came to us with acute access thrombosis, as we can see in this angiography from the radial axis, the stump of the cephalic vein. And what we did, the radial axis and percutaneous thrombectomy of this fistula. And then we did a sequential balloon angioplasty with Atropos 6 by 100 millimeters and 8 by 40 millimeters. Because there was stent graft, residual thrombus of the stent graft of the stenosis, we implanted a stent graft through femoral vein access, and we ballooned the cephalic arch restenosis. And the patient were on a hemodialysis session on the same day. The second clinical case, a 37-year-old woman with autoimmune glomerulonephritis with end-stage renal disease. Her hemodialysis access was a left brachial-axillary AV fistula. She became with access dysfunction with high venous pressure, pain during the hemodialysis sessions, low flow, prolonged bleeding at time after needle withdrawal. And in this angiography, we can see a cephalic vein high-grade stenosis in the middle of the arm. As we can see here, a lot of collaterals arising from the cephalic vein before this stenosis. And we did also a radial access and a sequential balloon angioplasty, first with Atropos 6 by 40 millimeters, and then this is the 6 by 40 Atropos, and then we used a non-compliant balloon, the Hermes 10 by 40 millimeters. As you can see, the waist of the balloon after prolonged inflation time and this complete inflation, releasing the waist of the lesion. And this is the final angiogram. We completed it with a drug coating balloon to avoid restenosis in the future. And we can see the good result. The patient was put in a hemodialysis session the same day and was discharged home the next day. So in conclusion, AV fistula stenosis is the most common hemodialysis complication. It can affect dialysis access, quality of life, and even mortality. Angioplasty is the preferred treatment. These lesions are hard to treat. They are fibrotic. stiff and elastic, tends to have a recoil during the treatment. And our initial experience of Atropos and Hermes balloons showed good trackability, good inflation and deflation time, high pressure resistance, and we can open even very hard and stiff lesions with these balloons. Thank you very much.